here we are with Dr. Robert Varnam having a conversation around the future of general practice. So Robert, we've had a discussion today around the future of general practice. What are the key things you think general practice needs to do to prepare itself for the future?
I think most of what we need to do, Andy, is to do with building on the strengths we already have in general practice. But acknowledging that that might mean working in some quite different ways. It might mean expanding across our boundaries quite a lot. So I think we've got in general practice a model of care and professionals who are already holistic. They're already generalists. They can deal with the majority of what patients need in the community. They can do cradle to grave care, preventive and treatment, crossing the whole boundaries, which is not just great for patients, but it's also incredibly good value, and it's much more cost effective than splitting up a patient into lots of specialisms and treating them in a hospital.
Sure.
But as we look to the future, I think the fact that all around the world our populations are getting older and our patients are coming with more and more long-term conditions and care gets more complex. I think GPs are recognising that what we've got is great, but we need to work at much more of a multi-professional team level. And that first of all means growing our teams, having more nurses and healthcare assistants and therapists and mental health therapists as well, working as an integral part of the team. And then secondly, I think increasingly we're recognising that because health is broader than medicine, because a lot of the influence is on, frankly, whether our treatment works, yet alone whether people stay well and healthy for their life, they depend on things outside my control as a doctor. I can't prescribe people into wellness most of the time. Actually, people are recognising that general practice as a team not just needs to grow, but needs to reach out across boundaries and work with others in the community who can be more proactive, they're more well-placed and more skilled sometimes in dealing with social issues and determinants of health as well.
So how does general practice free itself up from the daily acute demand and the rising planned care demand to have the conversation around prevention?
For us in the UK, as I see it around the world, including in New Zealand, the big areas of change for us are firstly to build patients' ability for self-care and self-management wherever possible, so that they are better enabled to look after themselves. That's good for the patient, it's good for us. Secondly, to make much more use of technology as partly an enabler of self-care, partly just improving efficiency. You know, if the patient really just needs a question answering, why are they booking a 15-minute appointment with a GP to answer a question?
Absolutely.
Email it. Crazy not to. And actually technology helps us go a lot further as well. And then I think the third one is to look at the team and ask who's the most appropriate person to deal with this specific piece of demand, acknowledging that although we as doctors are fantastic and we could do almost everything, actually it's not the most appropriate use of the rare skills that GPs have. So kind of sharing that workload out with others. I think it's good for patients, but crucially, as you say, it frees up that much needed medical time to do some other things.
So traditionally some parts of the medical system and professions have been quite isolated. How do we break down the barriers so they actually collaborate more openly if they're on different sites and in different settings?
I think that's a huge challenge that we all face, and I think at a system level, I think governments, payers, regulators and leaders need to be asking what barriers they can remove. And it's often about removing disincentives to collaboration. When you speak to professionals, they usually want to collaborate and would value the opportunity to, but they feel that the system makes it hard. But then the second thing I think is that often when professionals do start to come together, the organisational boundaries, the need to compete, the worry about financial viability, and we've got to keep paying the staff, so if I lose business, what do I do, is a genuine concern people have. But if you start conversations around clinical care and specific opportunities to improve that would use collaboration more, then I find all around the world you do see it's easier to get that collaborative working going. And from that then follows some conversations about, well, what should we do differently that's structural that would help make this sustainable? But starting with the patient care usually works better.
And so thinking about the system itself and the structural challenges we have with them, both in terms of the legacy funding issues and the legacy policy issues, what's a way forward to try and break those down, and how do you engage the different parts of the system to work together and collaborate on a different future?
I think for us, and I suspect in the conversations I've had with colleagues here in Auckland, one of the big things is to find the multiple changes we need to make that help the money follow the patient, and then help the system work so that the patient is being cared for in the best place for them.
Yeah.
And all of us are going into that conversation assuming that we need to have some shifts. We need to shift some care that's currently done in a hospital out into the community. We need to shift some things from being rescuing people once they're really sick to helping them stay well in the first place and avoid those exacerbations that cause them to go to the ED and be admitted. And that there's a lot of structural change and a lot of changing of rules and payment systems that needs to happen, and particularly when you start in different places they need to look different. But I think the fundamental principle for all of us is, if we're wanting care to shift, money has to shift with it. Why don't we find more and more ways for the money to be attached to the patient, not to the provider? And then it happens more naturally. I think that journey to working like that will involve some people getting less money than they get right now. There's some real anachronisms and difficult bumps on the road. But in terms of the principles, I think it's very hard to imagine we're going to get where we want to go without some big changes.
Sure. Now, in England, the Nuffield Trust and King's Fund seem to play an incredible role in thought leadership in the system, and we don't have a natural home for that sort of thought leadership in New Zealand. Do you have any recommendations around how we might go establishing a function like that to be the independent voice in the system?
It's a really good question. I think the two thoughts I have are, firstly, that it doesn't necessarily take very much to set those things up. It does take a long time for them to become credible. And I think you're right that the quality and the independence of the voice both matter. And for people to have trust in that takes time, regardless really of where you set it. You know, whether it's in an academic institution, a membership body, a governmental institution, or sort of a quasi-governmental institution, or something totally new. But then my second thought is that I'm really struck, meeting at a conference like this, how many people have great ideas already. How many people have the beginnings of an evidence base behind that, even just working the group of practices or just even a large practice in an area. I've had conversations with people who feel they've got something to share and others could benefit from. I've similarly had other people talking in open sessions saying, if only I could find someone to talk to about this or that, and we're struggling with this issue, has anyone else tried this? And so I think the other challenge, which I am posing to ourselves in England as well, is how do we also mobilise the existing wisdom, the evidence-based experience that exists in our professionals. And it does seem as though that sometimes works quicker in terms of spreading good ideas, avoiding people reinventing the wheel. It doesn't have the same kind of academic clout or independent voice of a great institution, but actually sometimes it might achieve even more quicker, and it could just be peer-to-peer sharing in networks. And I'd be interested to see whether the ministry in New Zealand, whether the PHOs, the Royal College or others would be up for that kind of social movement approach to sharing ideas that might work really well and fill some gaps.
Yeah, and we've already had some conversations with the college interestingly today about that thing. The final question I was going to ask you was, you know, often in New Zealand I think we have a tall poppy syndrome, and so rather than celebrate the tall poppies, we accept them for what they are, and don't necessarily reflect on how well our system's operating with other systems around the world. If you were going to give us some feedback around what works really well in general practice and the health system in New Zealand, what would they be?
I think it's really interesting to see, firstly, the enthusiasm that your GPs have for being GPs.
The thumb test today was...
Yeah, it was amazing.
Yeah, it was really positive.
It was very positive, and I've asked groups of primary care physicians around the world how they feel about their work, and the future of it. And I think today's view from general practice in New Zealand was one of the most positive I've ever encountered. I think that's something to celebrate and to build on, actually, in terms of the commitment. I think the other thing is the amazing willingness of people, in the face of challenge and a lot of hard work, to be challenging themselves to realise more of the potential of general practice. So there's a huge appetite here for people to be asking, how do we partner better with patients? How do we support patients to be taking more responsibility for themselves? How do we link with our communities? How do we better recognise the fact that actually we've got different communities here and we should link with them differently, and that will look different? And there's just a very natural acceptance of that, and a desire to really make something of that, which is sometimes, you hear people talk about that sort of principle and it feels a bit tokenistic. In New Zealand, I hear people talking about it and they're all pushing on the boundaries to try and make it happen.
Sure.
Which I think is amazing, and I think you should be really celebrating that. I think one of the big challenges is that right now people are struggling to see how this more multidisciplinary team approach to care is going to work at scale, how it's going to be spread, when, just like in many places, the funding makes it difficult. There's a sort of big set of disincentives there. And there are groups of practices that are making it work. And I think one of the questions will be, well, how are they making it work against the challenges when other people aren't? And then secondly, are there things the system could do to remove some of the barriers or the brakes, so that not just the massively enthusiastic and hardworking innovators can make it happen, but actually everybody can make it happen.
Excellent. That's good advice. And hey, I for one have enjoyed talking to you today and listening to you speak, so thank you very much.
You're really welcome.